Hi, I'm Alkananda Behera. I'm a resident in the Department of Anesthesiology, Pain Medicine and Critical Care at AIIMS, New Delhi, India. I, along with my mentors Professor Vimi, Professor Rashmi, Professor Anjan and Professor Sunesh, have the honor in presenting our abstract at the ASTRA Spring 2019 meeting. I have the great pleasure in talking to you a bit about our study, which is entitled Ultrasound-Guided Bilateral Rectus Sheath Block with Multimodal Analgesia versus Intrathecal Morphine in Gynaecological Oncology Surgery, a non-inferiority trial. Post-op pain management occupies one of the cornerstones of perioperative care for gynecological oncology surgeries that demand a vertical midline incision, which is quite radical majority of the times, extending from the xiphisternum superiorly to the pubis symphysis. Intrathecal morphine in gynecological cancer surgeries has conventionally been known to provide simple, quick and good post-op analgesia, but it is commonly associated with adverse effects like nausea, vomiting and pruritus that lead to reduced overall patient satisfaction. The rectus sheath block has emerged as an alternative means of providing midline somatic analgesia in an effort to improve care and limit opioid-related adverse effects. The objective of our study was to evaluate whether multimodal analgesia with ultrasound-guided bilateral rectus sheath block provides analgesia comparable to intrathecal morphine in this study population. The primary outcome was total post-op morphine consumption as administered by intravenous patient-controlled analgesia over 24 hours. The sample size was based on a previous study by Kara et al. In 2012, wherein the 24-hour morphine consumption was 12.6 milligrams in patients who received intrathecal morphine. Thereby, a difference between the groups of 5 milligrams was considered to be equivalent in our study. Simply put, if the difference of means between our two study groups came out to be less than 5 milligrams, then it would prove that rectus sheath block is non-inferior or equivalent to intrathecal morphine. Intrathecal morphine group received 4 microgram per kilograms of morphine in saline, not exceeding 200 microgram administered intrathecally before induction, and the group rectus sheath block received 20 ml of 0.375% ropivacaine injected into the rectus sheath space on either side under ultrasound visualization after induction of general anesthesia, along with intravenous dexamethasone, paracetamol and diclofenac sodium. Patients in both the groups received intravenous morphine via a patient-controlled analgesia pump for 24 hours in the post-anesthesia care unit. Post-operative nausea, vomiting, pruritus, patient sedation and satisfaction scores were scored on a 3 or 4-point categorical scale. Observations were noted at the previously mentioned time points. This image shows the anatomy of the block, where you can visualize the anterior rectus sheath, the posterior rectus sheath, below which lies the fascia transversalis, below which lies the peritoneal cavity. The target site for local anesthetic administration is below the belly of the rectus abdominis muscle but superficial to the posterior rectus sheath. The patient variables between the two groups were comparable with respect to age, weight, ASS status, total surgery time and total anesthesia time. The primary outcome, that is the total PCA morphine used in 24 hours, was 27.20 milligrams, which was statistically significant compared to intrathecal morphine, as you can see in this figure. This image depicts that the non-inferiority of rectus sheath block to intrathecal morphine was not proved in our study, as it fell outside of the margin of 5 milligrams. The secondary outcomes, that is the VAS score at rest, were also significantly higher in the rectus sheath block group compared to the intrathecal morphine group at 6, 12 and 24 hours post-op. And the VAS score on movement was also significantly higher in the rectus sheath block group at 2, 4, 6, 12 and 24 hours post-op. The time to passage of flatus was, however, significantly higher in the intrathecal morphine group, which recorded 46 hours compared to 29 hours in the rectus sheath block group. The patient satisfaction scores were, however, equivalent between the two study groups, as you can see in this figure. The present study failed to show the non-inferiority of rectus sheath block combined with multimodal analgesia in comparison to intrathecal morphine in terms of post-op pain relief in gynecological oncology surgeries. This signifies the efficacy of intrathecal morphine, which has been reported to decrease VAS pain scores up to 24 hours post-operatively and opioid requirements up to 48 hours. Visceral component is a significant contributor of post-operative pain in gynecological oncology surgeries, while rectus sheath block provides somatic analgesia alone. However, side effects associated with intrathecal morphine contributed to the lack of difference in overall patient satisfaction scores between the two groups. This Thus, the rectus sheath block can be used as an alternative to intrathecal morphine in gynecological oncology surgeries and thereby further enhance its role as an important component of fast-track surgery protocols. Thank you all for your kind attention. I look forward to meeting you in person and talking more about this topic at the ASRA Spring 2019 meeting.